Hey everybody, welcome back to the ECG channel. My name is Reed, and don't forget that you can follow along with this ECG down in the description below. It's linked. And don't forget to like and subscribe to the channel if you enjoy the content. So let's jump into this one. This is a scary rhythm, right? You know, someone walks in, you're working in the ER, and the nurse walks in, and she's like, hey, I need you to look at this. And so this is what you get, right? And so what do we notice when first thing I do is I look at the forest, right? And so I look at my QRS complexes and maybe I start, I don't know, V1 right here. And you notice that I've got a very rapid rhythm and it's wide, right? My QRSs are very wide. And you can see it is the same morphology and the same rate all through. So we have a wide, complex tachycardia. So we need to make sure, what's our differential? Well, first, differential is going to be monomorphic ventricular tachycardia. And then two, we have maybe like a supraventricular tachycardia with aberrancy. I would say it's more important to make sure that this is or is not ventricular tachycardia. So we've got a wide complex rhythm that's really, really, really fast. If I look at the rate of my QRS complexes, if I find a QRS that lands on a solid line, like right here, my rate would be 300, 150, 100. So anywhere between 100 to 150, I'm going to call that 130 beats per minute, right? So we've got a tachycardia, okay? And it's wide. And so first thing I need to do is I need to figure out what is my pretest probability that this is ventricular tachycardia, right? So I maybe evaluate, sure, are there P waves in front of my QRSs, right? Let's do that. And, maybe you could say I don't see distinct P waves that are in V1 usually has some decent P waves. I don't see distinct atrial activity before my QRS complexes. I don't see any here. I look at the axis of my QRS. That really helps me. And I notice that it is negative in my inferior leads. 2, 3, and AVF, the QRS is predominantly negative, right? I'm just going to do like a broad strokes QRS. So we have it negative QRS in my inferior leads, which are leads 2, 3, and AVF. That tells me that generally this wave of depolarization is going from down to up. So that's really making me think, is this ventricular tachycardia, right? Because depolarization is spreading in a direction that is not common if conduction is through the AV node just in aberrant fashion. Something else that I noticed that makes me think about ventricular tachycardia is my QRS complexes are often positive throughout the precordium, right? The only one that's just barely negative is V6. So that would be something called positive concordance, which usually we have transition, right? Not everything is positive, right? So if all my QRSs are positive in the precordial leads, or if they're all negative, that makes me think VTAC. But these are all things that are just increasing what is the likelihood that this is VTAC? I need to find some concrete evidence. The best way to find concrete evidence is with something called AV dissociation. And if you have AV dissociation, that is almost pathognomonic for, in this case, a ventricular tachycardia. And so what does that mean? Well, if I have a VTAC, I've got this focus maybe that's spreading waves across the ventricular myocardium from cell to cell, gap junction to gap junction in a very slow fashion, right? It takes a little bit of time. That's why it's a wide complex QRS, right? But obviously this is a tachycardia. And some people's AV node can actually take that signal and send it retrograde. Some people's AV node cannot do that. And so sometimes you'll have people that get retrograde P waves, but those retrograde P waves don't happen every beat because the AV node, we know, tries not to conduct really rapid signals all the time, right? So maybe it'll conduct every other, every third. But oftentimes, what you'll see is because there is not 1 QRS per 1 P wave, right? Because not every QRS is causing a retrograde P wave. You'll see something called AV dissociation, where you will see kind of random evidence of atrial activity or random P waves. And that tells me that the atria and the ventricles are not talking in the setting of a wide complex QRS. And so, if that's the case, you would be able to rule out SVT with aberrancy if you have that. And so, I like to just find a rhythm strip, maybe V1, and you look for little atrial activity. Remember, atrial activity is like little sharp deflections, right? They could be positive, they could be negative. And so what you'll do is you want to look on the smooth parts of these rhythms, right? Maybe on the ST segments and the T waves, and you want to look for kind of little bites or pokey kind of aspects, right? And so when I look through V1, when I scan through, there's a couple things I notice. I notice right here on that T wave, I notice that little bite that's taken out of, that's not in the rest of these T waves. I look right here and I see there's like a little sharp deflection right there. That little sharp deflection makes me think of some atrial activity because it's not, look how smooth normal T waves are. So that's not where what we usually see. You see some more bites being taken out here, right? You see a kind of a spiky negative deflection there. That's an odd shape. That might be some atrial activity. And so notice there's just some evidence of atrial activity just interspersed within these wide complex QRS. And so that is great example of AV dissociation, right? You're not going to see this in every lead. You're only going to see it in the leads that are really capturing atrial activity well. I find V1 to be good. You can also kind of scan through, like AVR is typically decent. Some of the inferior leads, really the limb leads, 1, 2, 3, AVR, AVL, AVF, and V1 are great for looking for AV dissociation. In this case, we get good AV dissociation in V1, right? Let's see, here's maybe even another one. And so because of that and all of the wide complex rhythm, we could really rule out this is not SVT with aberrancy, and this is very much so a monomorphic ventricular tachycardia. And so obviously you would treat it accordingly. So I hope this helps kind of you as you develop a system of evaluating wide complex tachycardias that are regular and monomorphic, right? Really it's SVT with aberrancy versus ventricular tachycardia, right? If you want to get better at recognizing SVT with aberrancy, well, you know that aberrancy has to have some type of pattern to it, right? Like a bundle branch block pattern. So you can start off by looking for that. Does this person have a history of aberrant conduction, right? At a baseline, do they have a right bundle branch block or left bundle branch block? Little things that can change your pretest probability as well. But in this case, we've got all the features for a monomorphic ventricular tachycardia at a rate of 130 beats per minute. So luckily, this isn't the fastest VTAC in the world. Hopefully, we can slow them down and convert them back to a sinus rhythm, right? You can do that with electricity. You can do that with antiarrhythmics. Yeah, hope this helps. If you enjoy the content, feel free to subscribe to the channel. And thanks for watching. Have a great rest of your day, and we'll see you on the next ECG video. Take care.